Hola a todos, buenas noches. Muchas gracias por
Hello,
conectarse
everyone.
a la quinta
Good
versión de
evening.
este Real para Latinoamérica.
Thank you for
Una actividad en
connecting
conjunto
to
entre
this Reel for
ILTS
Latin
y la
America, an
ALE.
activity between ILTS and ALE.
Estaremos hoy día moderando
Today,
este webinar
we
con
will
la
have
doctora
as a
Fátima Higuera de la
moderator
Tijera, la doctora
Dr.
Higuera
Fatima
es
Higuera de la
especialista en
Tijera.
gastroenterología
She's
y doctora
specialist
en
in
médica por la
gastroenterology
UNAM.
and PhD in medical sciences from UNAM, and she's the head of service of gastroenterology and hepatology at
Doctor
the
Eduardo
Hospital
Ireciaga.
General de México.
Así que
Dr. Eduardo
muchas gracias,
Ireciaga.
doctora
Thank you
Higuera de la
very
Tijera, por
much, Dr.
conectarse
Higuera de la Tijera,
y poder
for
moderar este
connecting
módulo. A eso
today
le
and
cedo
moderate
y
this
presento a
module.
nuestro speaker y a nuestra
So
ponente.
now you have the floor for the introductions. Thank you very much, Dr. Juan Pablo Arab. Thank you for the invitation. It is an honor for me to participate in this very successful webinars. I want to thank Dr. Arab, Dr. Roberto Hernández Alejandro, Dr. Rodrigo Zapata, Dr. Manuel Mendizábal, Dr. Josefina Bajes, organizers of these online events, which are really important to continue our education. It is an honor for me to be in this fifth Real Latam called Liver Transplantation for Alcohol-Associated Hepatitis. It is an honor for me to introduce someone whom I admire. He's a pioneer in the field of alcoholic liver disease, and in particular alcoholic hepatitis, Dr. Ramon Bataller. He is professor of medicine, head of hepatology of the Division of Gastroenterology, Hepatology, and Nutrition in the Medical Center of the University of Pittsburgh. And he has studied patients with alcoholic fatty liver disease, non-alcoholic fatty liver disease, critically ill cirrhotic patients. Many years ago, and particularly in the last 10 years, he takes part in a multidisciplinary team to treat patients with alcoholic liver disease, with studies in liver fibrosis, mechanisms and determinant of mortality of alcoholic liver disease. For example, in the case of translational studies, he's a pioneer on research on global public health aspects of alcoholic liver disease. He is currently principal investigator of the NIH funding consortium for translational research of alcoholic hepatitis. So with no further ado, Dr. Batalle, it will be a pleasure to listen to your conference. Thank you very much for your kind introduction, Fatima. Thank you, Juan Pablo. Thanks, Ale. I mean, I think this is the 30th time I speak to Latin America via Zoom without being there in person. So I have sort of withdrawal syndrome of Latin America, and I hope to be there one day. Just as Fatima said, I'm going to speak about liver transplantation for alcoholic-associated hepatitis, which is something relatively recent. I have experience in both American centers, the centers that didn't exist when I arrived. I will speak about data. I will give you data, and I will tell you what I have experienced in real life, since there are many more questions than answers in this field. And I will try to make this more fun, because this time of the day we're very tired. I will speak about alcoholic hepatitis, diagnosis, and current therapeutic options that we have now. I'll speak about how to select patients for early transplantation in the case of alcoholic hepatitis. Outcomes, I don't know how to say it in Spanish, the outcomes in terms of survival of this modality of transplant. Something crucial is how to avoid the ratio of recidivism in those patients. And the last slide is what we need to do, which is the majority. There are more questions than answers. We all know what alcoholic hepatitis is. Patients who come with jaundice, on many cases, the first manifestation of liver disease. Younger people suffer from this now. In countries such as Canada, US, or UK, there are more young women in recent years. And there is a lot of mortality. Therapies are not very effective. We have to be careful that not every patient that drinks and gets jaundice has alcoholic hepatitis. The use of biopsy was quite cultural. In Europe, they do it a lot. In US, almost never. And in the National Institute of Alcohol and Alcoholism, we held a workshop, a sort of meeting, and we saw how to when to do a biopsy. This is something we did with Dr. Patrick Ama, a very good friend. I remember that our consortium established that confounding factor are patients that are atypical. They say that they do not drink, but they say no because they do not drink. They have alkaline phosphatases or transaminases very high. If there are confounding factors, a biopsy should be made, especially if the patient will go to transplant. I've seen cholangiocarcinoma, cocaine systemic hepatitis, and other things that are not alcoholic hepatitis in a patient that drinks alcohol and becomes yellow. In theory, patients that go to transplant must have something probable or definitive. Someone wouldn't go to early transplant if there is something very strange that is not typical. And I don't do a biopsy because I could be transplanting a lymphoma that is infiltrating the liver in someone that is drinking alcohol. I've seen that. Sometimes I send tweets. And this is useful for my presentations too. With Juan Pablo, we have this passion for Twitter. Many people said, do you still give prednisolone and when do you stop it? Well, this is a study that we did with Juan Pablo with many patients from several centers in the world. We are now establishing a network. Many of you participate. It's called ALCHEP. And there is a window, ideal window for prednisolone or prednisone works. A melt between 25 and 39. Less than that, it doesn't work. And this is another study with Dr. Duarte Rojo, who will start in Northwestern. He's a Mexican too. We did a study showing that Lil on day 4 is the same as Lil on day 7. And this has been confirmed in other studies. And why is this important? Infections in the setting of patients treated with steroids are more serious. If a patient goes potentially to transplant, I give cortisone and at 4 days hasn't responded at all, I stop. That has been confirmed because one of the problems not being able to transplant those patients is because they can have fungal diseases or other infections, difficult to treat. So there is a contraindication for liver transplant. This is debatable. There could be several opinions about it, but that is mine. Why this of early transplant for alcoholic hepatitis? And how to do the patient selection? I don't know whether in your centers do transplant with this indication, but whomever I talk to say, look, there are so many discussions. We take half an hour, 40 minutes. Whenever there are one or two patients, we know that that day we're going to finish late. These comments are not very scientific, but are from real world. We all know that in the US and many parts of the world, alcohol is number one reason for patients to require transplant. Although there are no data of alcoholic liver disease with the phenotype of alcoholic hepatitis in general, there are many studies, this is a very old one, that there is under-referral of patients with alcoholic liver disease. They are transplanted less and they are less accepted. There is a bias against those patients, even those that are in abstinence. There is no study demonstrated that has demonstrated this bias. It would be very interesting to demonstrate this under referral bias. Maybe, Juan Pablo, we can do that in some of these countries. How many patients are diagnosed in primary or secondary healthcare centers who are not sent for transplant? Well, the idea appeared through a paper, a hallmark paper by Dr. Maturin, Belgian-French group. They have led many of the clinical trials. He published this in the New England. When something is published in the New England, is the Bible. And he did a cohort of patients with alcoholic hepatitis without waiting for 6 months who had not responded to prednisone. He offered liver transplant, and he saw that at 2 years survival was more than 70%. And this was compared with the same cohort that hadn't responded to steroids. And please look at the mortality. It's very, very important. So there is young people whom we are not offering a treatment that exists that can increase survival from 20 to 70%. It's changed the way things are done. And so there's been a lot of movement in transplant. There's another tweet I sent shortly ago. If we see this graph, the number of patients due to alcoholic hepatitis in American centers has increased enormously. This doesn't happen all the time in Europe. In Spain, it's starting now. Up until a short time ago, nobody thought about that. And now that I'm going to go back to Spain, go to Barcelona, it can't be that there is a bias against doing this transplant in some patients. There is an ethical dilemma here, a dilemma we could be discussing a lot. I sent another tweet about it. We are not priests or policemen or judges. We're physicians. We are nobody to say who deserves a transplant, but who will benefit with a transplant. If we demonstrate with solid arguments, truthful arguments that are well confirmed, that by choosing patients properly, they will not have a relapse, well, those patients will survive. Who are we as physicians to deny those people a transplant? This is an ethical debate. Sometimes we offer retransplant with a kidney transplant to a person of 68 years old that had a transplant due to NAFLD and a 4 post-transplant. BMI is 42, and we have no ethical problems. Or we transplant a patient. Well, I've seen no study that says that you cannot have some new treatments of hepatitis C because some years ago you were using heroin. I'm sorry, you don't deserve it. Well, we shouldn't say this now. So our mission is to provide health and not to judge.
Things will vary based on the culture you're dealing with, but patients who have failed the detox more than twice aren't accepted how we define detox? Well, that was a long discussion because we even had to define it very precisely. Is it outpatient, inpatient? The discussions or debates on these patients are quite complicated. It's not.
Recording in progress.
Para un paciente, para un médico esto no es grave y para el otro sí.
What might be easier to deal with for one physician might not be for another. So basically, we rule out personality disorders, major depression, drug dependence, bipolar disorder, eating disorder. Another criteria would be the use of recreational drugs. Very few do not consume marijuana in certain populations, or tobacco. So I'm really trying to, like I said, just get real world data for you. Pick up on criteria that wouldn't be picked up otherwise. Because yet again, it depends on the city you look at, different factors, socioeconomic, previous hospitalization due to mental health illness, addiction treatment for substances other than alcohol. This is in order to provide a definition who would have a profile. And it's very difficult to work with these patients. So to get precise metric methods is practically impossible for this. So there's a lot of need for consensus. Now, this is just to illustrate the following. Now, how this was presented in a committee. This is recovering outcomes of patients denied early liver transplant for severe alcohol-associated hepatitis. Now, you can see that there's a more important implication in a person's survival versus when it comes to, for example, giving some antibiotic versus not, performing an exam or not. It's not that often that you see one decision accounting for such a high difference in outcomes, in probability of survival. Now, personally, I'll say, and not because I devote myself to studying alcoholism, I try to be fair. I try for the system to be sustainable. If on the first days I perform transplants, if all of them are going to relapse, as we'll see, a lot of them will die early. It's very possible that the program will not last, which implies that other people will be dying because the program will not be active. So it's a difficult responsibility. But I'm sharing this with you just to give an idea of the implications of this decision. Now, this is something I tweeted about a while ago. Perhaps the most important decision a hepatologist can take. No other decision can have such a large impact on a patient's life than this. I'm familiar of no others. Now, in terms of the outcomes, now here, when it comes to transplanting someone with NASH who doesn't respond to steroids versus not, here we can see survival with early liver transplant for alcoholic hepatitis. Now here we can see some factors, learning curve. And here we have an AJG paper from 2017, and you can see how the mortality goes down. Correction, the survival goes down after very few weeks after those who do not respond. After LT, there's hyperemia, dark, soft. So the first transplant we performed at UNC, the surgeon sent me an image from the OR and said, I'd never seen a liver so black, hyperemic, in a young patient. Most of these patients will die a few weeks after. So this affects the young as well, very young people. So after those two initial trials, there was a large American initiative led by McLucy Terrell from the East Coast and so forth, who performed the Accelerate AH trial. In 14 centers, and here was the first case they published with survival. Tried to get better, very similar to the survival of the other patients with alcoholic liver disease, 84% after 3 years, very favorable. You can see that we were denying them outcome just by being too judgmental. Because of our prejudice, without well-established medical criteria. What would be the long-term survival? Here we have something from New England. There was better follow-up here, and this was prospective, 2-year follow-up. You can see the survival. It's a bit lower than in the others. But look here. Practically all the mortality from transplant hepatitis, from severe acute hepatitis, occurs in the first weeks. Why? Well, because there's a multi-organ failure. You have to see where's the risk and the futility. And a lot of occult infections from parasites, fungi, from the steroids. So it's necessary, in my opinion, to identify why this subgroup of patients die so quickly, because this drop here is almost as marked as the other one. And why would there be a subgroup of patients that die so quickly? And perhaps perform prophylaxis for infections. Here's something confidential. We've seen, and there are some non-published trials that are starting to see something interesting. In the era of COVID, the alcoholic hepatitis patients die less initially, especially when treated with prednisone. And this hasn't been published, but this could be a bombshell. But it's probably not because they came better to the hospital, but because the patients and their accompanying members who used masks. But perhaps that would be the only explanation we have. So they're more immunosuppressed than we thought. When we looked at this 20 to 10 years ago, when I looked at data from Asia, in Asia, I remember even back then, a lot of people used masks. But in the West, if you saw someone with a mask, and you'd think, oh, well, that person, they had been in chemotherapy or that they're immunosuppressed and so forth. It appeared that the use of masks could be life-saving in these patients. Very interesting data. It should be published soon. Now, here we're looking at alcohol recidivism. And many of them, because of coma or other factors, you can't treat them, perform a pre-treatment, but with the young patients, they tend to relapse earlier. They're younger than what you'd see in other liver disease. Well, in my experience, even though many of these relapse, they don't lose the liver or damage it as bad as in other alcoholic liver disease. They start to drink, and the family starts to put pressure on them. They start to pick up on that, and well, this is a meta-analysis. And here we can look at the data on relapse. Depending on the criteria for alcoholic hepatitis versus cirrhosis, well, you can see the difference when comparing for liver transplant. Nobody would expect that more poorly selected patients with poor withdrawal and without counseling would be the same. This is in Accelerate Day Age, here we had 3-year follow-up, and we could see that a third, in my experience at UNC, it's been more than half, at least in my experience, of the probability of relapse. But at least in the 2 centers, where we performed about 50 transplants in total, and most of these relapsers weren't that catastrophic. So They receive more than cirrhotics, but perhaps not that much. Here we have in Accelerate, they showed that those that drank had worse survival than those that did not. There are several consequences. For the person that drinks excessively, you think that will you think they're coming, or will they be embarrassed after all they've been through? No, they might not do it. I say this because attributing all the graft loss to alcohol is not precise. It's the effect of alcoholism which implies the lack of immune suppression, more infections, and so forth.
This is the follow-up of those north of France and Belgium, and they saw that when comparing early transplantation and the standard transplantation group, there are more patients that are recidivists in that group. Something to be expected. And what are the predictors? Well, here there are some commonalities. There are also differences that are quite cultural. Younger people live more. They did here lack of complete acceptance of diagnosis. Well, here you have three types of patients. When you speak about alcohol, they say, "Oh yes, I drink and I have no problem." The other extreme, saying no all the time, and you're lucky if when they see the seventh doctor, say yes, and another one can say, "Oh no, it could be genetic, etc." And they start to speak about alcohol, the intermediate group. In my experience, that all depends also on the one who asks. Juan Pablo can say that you're going to see patients. Residents say, oh, he does not drink, but you who are an expert, you are a specialist, you know how to ask in a more tactful manner. You have done this more times. How many times are being told that the patient doesn't drink, but you just talk to this person? After 1 minute, they say, yes, I am drinking. So the underreporting, well, also there is a role played by the one who asks and how it is asked. I didn't include this in this presentation, which is the power of PEth. PEth has revolutionized programs. The patient cannot change urine, and it captures almost 1 month of alcohol PEth in the follow-up of patients who drink again. PEth has changed everything. It is incredible. It has changed the way of following up patients. It costs $150, and for example, Spain doesn't have it. I say that because we want PEth to be cheaper, a blood test that tells you how much you have drunk the last month is amazing. I mean, there is a recent paper. If you find my Twitter, it is there. Okay. There are several studies. This is the famous HRAR published in Alliance by Andrea de Gotardi many years ago. Well, this wasn't alcoholic hepatitis. We were all of the alcoholics. And with Jose Altamirano, a Mexican, very good friend who is in Barcelona, we did a study following up 200 patients for about 15 years. And we found that young people and those who drank the most and those that had a higher number of past alcohol treatments are the ones that drank the most. In Spain, there wasn't transplant at the time. Are these this same criteria for prediction for transplanted and not transplanted, there could be a small change. I don't have a scientific answer. This is just speculation. Well, here, besides predicting who will drink, what can you give this patient so that he does not drink? Can you offer therapy, a medication? Are all medications good for transplant? There are no studies, no good study about this. This is a review we did with Juan Pablo in Nature Reviews on how to treat alcoholism after transplant. There were lots of discussions because everything was speculation. We need studies, and this is a summary on medications. There is just one trial of giving baclofen to cirrhotics. It's the only one randomized, well done in the history of mankind. Just one trial well done for these patients. With just one good trial, do you think you can have sustainable evidence? I sent a tweet about that. People in Twitter give so many vehement opinions, and I'm humbler when I give an opinion. I don't know. There are very few studies. Well, we say that it seems that baclofen does well and that it is very safe. The problem is that it's not in every country. Acamprosate, there are no studies, but could alter the metabolization. But you have to be careful if you have kidney failure. Also, naltrexone, if you also have opiates, you can have opiate withdrawal. Some people in Twitter defend all this, saying there is no study. These are a couple of studies. Well, this is a study published very shortly ago from Massachusetts. They reviewed what happened with non-transplanted alcoholics with cirrhosis treated with something versus not treated. This study was impressive because they had, I don't know how many patients, there were about thousands of patients. Those treated did better, had less decompensations compared to a treating group using those 4 drugs. They said that they saw positive effects. This is retrospective. But it is a paper with lots of patients. Another study, acamprosate versus baclofen. They are similar, but maybe acamprosate does a bit better. This is a retrospective study. I've lost fear for acamprosate because at the beginning there were no studies. There were some questions on hepatotoxicity. So now we have many more discussions since we're in Twitter on a daily basis. On a daily basis, we have been discussing with experts. That is wonderful on a daily basis. There are some discussions with Elliot Tapper regarding naltrexone, and many give opinions. And there is an exchange of experiences on a daily basis. It's fantastic. So I have seen that they are equally safe. In general, I give baclofen to the one that has a lot of craving and acamprosate to the one that has less craving. This is what I do. This is homemade because there is just one study. You have to be very prudent. And the last slide, I want to go to questions. This is the list of unmet needs in an area which is embryonic, is emerging. There are more questions than answers. For example, I would like to see if there is referral bias for alcoholic hepatitis. I know about physicians and centers who do not want to transplant them. There are some physicians who do not send those patients for transplant because they do not agree, because they do not have the sensitivity. Until one day, Well, I've seen physicians that have never sent anybody, and then they see a teacher from a school. I remember a teacher with two children with no job started drinking. A very good woman with two young children has alcoholic hepatitis, and that physician who didn't send anyone well changes his mind. It is something that implies a lot of emotions. But I've seen big changes when they had to struggle for someone and that someone survives, and you realize that without you helping that person would have died. Well, very few things are like this in medicine. Then public and patient awareness. There is very little education, public education and patients' education, predictors of spontaneous recovery. So you do not do a useless transplant, futility. How can you predict that? An induced transplant, well, these patients die immediately. Well, we need better biomarkers for infections, fungal infections. Some of them, maybe, well, we need more predictors of futility. How to refine selection criteria and local predictors. You start to take a look at local predictors, adapt guidelines and studies to your own setting. Post-transplant care to avoid early mortality. If you have to give antifungal treatment much more long before the transplant. How to do trials to give a motivational therapy, cognitive therapy to prevent relapse. And finally, something that we have done, live donor. There is one live donor. There is a selection bias because a family member that will give liver, and that family member lives at home. So you have the policeman there, probably. I don't say harassment, but moral control so that you do not drink anymore. So there is some possibility that you give a live organ to your relative. Maybe the ratio of recidivism goes down. This is something we have to study. And that's it. Thank you very much. Now I'm quite willing to answer your questions. Excellent, Dr. Bataller. Thank you very much for this extraordinary conference. We have prepared for you the session on Q&A, a roundtable with excellent panel members. We will invite them to join by turning on your cameras. I will read some relevant aspects of their curricula. Well, I will mention some important things. First of all, here we have Dr. Luis Antonio Diaz from Chile. He is specialist in internal medicine and gastroenterology. He was trained at the Catholic University of Chile. He is a clinical researcher now with interest in liver diseases, alcohol-related liver diseases, and alcoholic fatty liver disease, liver transplantation. He co-leads several multinational studies regarding alcohol-related liver disease, and he's the founder of the Omega Observatory of Liver Diseases. Welcome, Dr. Diaz. We also have with us Dr. Maria Laura Garrido from Argentina. She's specialist in internal medicine and hepatology. She does his practice at the Ramon Carrillo Hospital in San Luis, Argentina, and she's member of the subcommission of the Argentinian Society of Hepatology. Welcome, Dr. Garrido. Also with us from Brazil, Dr. Roberta Chavez Araujo, gastroenterology, hepatology from the Division of Gastroenterology from the Department of Internal Medicine, Hospital de Clínicas from the School of Medicine, University of Sao Paulo, Brazil. Welcome, Dr. Chavez. And Dr. Maria Cecilia Cabrera from Peru. Dr. Cabrera is gastroenterologist, hepatologist, head of the unit of liver of the Guillermo Almenara Hospital in Lima, Peru. She's professor of medicine from the Universidad Nacional de San Marcos, and she's member of the board of the Peruvian Society of Gastroenterology. Welcome, Dr. Cabrera. As you can see, we have a panel of excellence panel for our roundtable, and we have a very enthusiastic audience. We're so happy about that because we have many congratulations for the conference given by Dr. Bataller and many interesting questions that I will read. I will read those questions so that we can answer them. They are asking something very interesting. I would like to ask the incidence of acute cell rejection after transplant in the context of alcoholic hepatitis. Is there any evidence about acute cellular rejection in this context? Thank you very much for your comments. I'm so happy to be here with panelists. As far as I know, there are no data from studies as of yet, but my experience is that that type of alcoholic that when they have a relapse and do not come to consultation, I've seen several of them with signs of rejection. It's been because they have not taken the immune suppression. There are some that take just a little bit, the ones that do fibrosis, and the other one that drinks a lot and doesn't come to consultation. They are the ones that have the big rejection. In these cases, there is although less rejection than in other liver diseases. Thank you, Dr. Bataller. We are asked the deficit of vitamin D in critically ill patients. Increased filtrating bowel in critically ill patients that can worsen their progression. Has this been assessed in patients with severe alcoholic hepatitis? Is there any relationship with deficit of vitamin D in those patients with severe alcoholic hepatitis? Very good question. I like this because we did study that lack of light causes addiction. It causes not only depression. Well, that's why I'm leaving Pittsburgh, because there is no sun here. Well, almost all of these patients have a big deficit of vitamin D due to malabsorption, lack of intake, and bowel damage. There are some studies that show that vitamin D can improve patency of bowel. I have to remember that there are studies with vitamin that hypervitaminosis D can cause cancer. There are these studies is not to give vitamin D for 14 years non-stop to any cirrhotic patients. You can give those vitamins, but very carefully. All of the vitamins that go to the nucleus, I respect them a lot because cancer increase if they are given in Thank you very much, Dr. Bataller. Oh, there are so many questions that are so interesting. I will read one. We know that anemia can be a poor prognosis factor in the case of liver transplant. What do our panelists think about severe sarcopenia? Do you think it is a contraindication for transplant patients? let's see what you say, but I say that these patients, since they have sarcopenia, and you rehabilitate them, they die. It's not the same as a chronic patient. When you see the curves, it's to send them to physical therapists. But, well, here you have to bet. I fully agree. I would like to greet Dr. Bataille. The topic of sarcopenia is quite complex. There is evidence in alcohol hepatitis, and we have seen that in Chile the prevalence is 90%. And we know that those patients are immune suppressed. Many of them have kidney failure. It's very difficult to get them out of that situation. Those who do not resolve the alcohol-related hepatitis, you shouldn't expect to rehabilitate them. But we have to be very aware of their nutrition and post-transplant management. This is something we have to do, that physical therapy, etc. There's something I didn't say, and that is quite interesting. The patient that I see more in the US than Spain because of social isolation. A patient that has hemolytic anemia with hypertriglyceridemia, cachexia, etc. They are usually patients with psychiatric comorbidity, with poor family support, and they are not assessed. These are patients that come even in a wheelchair. They cannot walk. They usually do not go to transplant.
Yes, very good. Well, it's it's very common, the management of withdrawal, perhaps in Latin America, perhaps we don't have baclofen. No, here we have a question, a very interesting one. Do any of our panelists have experience with clomidazole for management?
El clometiazol, que no existe en
Clomidazole, which doesn't exist in the United States, and we can see there's more withdrawal to the lack of it. At high doses, it can be you can do well. Gabapentin, if you have gabapentin in Latin America, you might have it there. It's another GABA agonist, a different receptor, but there's studies, positive trials on that.
Bueno, siguiendo en este contexto,
Along that vein of
manejar a
how
estos pacientes,
to manage these patients, I'm being asked, well, how you should perform follow-up on these patients post-transplant with interdisciplinary groups. Would this be obligatory? What would be the multidisciplinary team that would be ideal in this context for providing care that leads to avoiding relapse? Dr. Cabrera, if you could start, since you have experience in management of withdrawal in patients with alcohol consumption problems, Dr. Cabrera.
Yo quería comentar que en el Perú nosotros
To select the best candidates. The family support is a key factor. Yes, I agree. I like the question because, in theory, well, you can see low, high, or medium risk of relapse. And if they have a higher risk, you provide more follow-up. I would consider all the early transplantation high risks. You'd have to conduct follow-up with a multidisciplinary team. And I agree with that. The best social worker would be a dedicated family member, a concerned family member. And Latin America is strong in that sense. At least the family has a significant power, as a healing element. me. It's an honor to be here with you. I so important that the family support for them to be involved. It was identified as a strategy that should be centered on in post-transplant, especially in early post-transplant. One of the associated factors to less relapse, it would be the presence of caregiver support. So that can really complicate the situation and increase the chance of relapse. So it's an important factor. Yes, I agree. United States it has the biggest, has the most difficult task in that sense due to the social structures, not the lack of affection. Sometimes people can't even skip work to take care of others. There's really no room for that. So, and that's something that people won't always be willing to do. I don't know if there's any cases where you could get groups that will help patients without that support system. It could be used as a surrogate, a solidary group that can provide support amongst each other, especially in cases where they've lost the family group as a source of support. So, Dr. Laura, you have something to add? Now, Argentina has good programs and a lot of experience in liver transplant. Dr. Garrido, go ahead. Good evening. Thank you for having me. In my experience, I was working in a transplant center, and now I'm working at a hospital where we don't have transplants. And besides the interdisciplinary team with psychologists, psychiatrists, social workers, the family, which is important as always. Now, when patients, we've had good results when patients assist to AA, for example. It helps with containment, and sometimes it's the same group. It's sometimes the people that attend the groups, the friends they meet in the groups, sometimes go to their checkups with them. Yes, AA, a lot of sponsors who follow an ex-alcoholic with experience in it. So a sponsor can help to keep an eye out. So there's a lot of strategies. There's people that have large families, but this could be an option for people with smaller ones or without families. And well, AA, Alcoholics Anonymous, does not work as individual treatment to justify a liver transplant without alcoholic hepatitis. For that, almost all centers resort to the need for counseling, and they don't accept AA as an individualized treatment. But it can be good for support. I'm not dogmatic in that sense. If it's good, it helps. We have Dr. Roberto Hernandez Alejandro. Dr. Hernandez, welcome. Go ahead.
Doctora Higuera,
Thank
excelente
you.
coordinación. Ramón, excelente presentación.
Ramon, great presentation. A lot of turnout, almost 150, which has been a great turnout. So thank you very much to all the organizers. Thank you to Juan Pablo Arab, the people from ALEJ who are working with us in this. I have two quick questions, Ramon. I'm in Rochester, New York, but to the north of you. First question, PEth, that you talked about in this testing, which is so interesting. It can take up to 2 weeks in obtaining results. The phosphatidyl ethanol. Well, if a patient who didn't get better after acute hepatitis, so if they get better and then get worse, well, you perform PTH and they have deterioration and they take 2 weeks to come in. So they can come in 2 weeks later. And we've even made poor decisions because we don't get the results for phosphatidylethanol, PATH. So PEth in plasma, because it's done in total blood, and there's few laboratories that can bring it to Spain. So it would be great to have PETH, have it in 4 hours a day even. But it's been catastrophic in some cases. Well, how to what degree does that interfere? And not you as a hepatologist, because I know you want to provide the possibility of transplant, because we know they have good survival. But my question is, what do you do when the patient says that they haven't been drinking? What do you, if you've got a PETH and it comes out positive and the patient requires a transplant? Well, when it's positive, well, the data from it is brutally specific. It quantifies PTH over 50. I haven't seen any case, only one lady who would produce, well, we see all the, she had done her homework on the condition. She even put yeast in the urine when she'd come in to consult. I say this because it's the only case that I've seen of a false positive. No. Here, a paper came out in the Journal of Hepatology. 25% of NAFLD that don't drink had positive PTH or a positive metabolite. The underreporting is significant. I'd like to put together a paper, since we don't stop to work together. One of the papers that we have to perform is prevalence of underreporting and underreporting predictors. For example, in Latin America, now sexism is a problem that's prevalent all over the world. Women feel more stigmatized than men. And there are countries where it's impossible to accept it. So there's more underreporting due to stigma, shame, due to the sexism. The woman doesn't have right to have a weakness or an addiction and so forth. Only men can have addictions. That's another of the factors that we have to improve on as a society. We have to have the sense. We have to ask in our visits if there's stigma.
Para hacer un Oscar, un premio de Oscar al mejor underreporter.
No.
Son gente que es capaz de llorar y prometer.
These are people. Well, the predictors of underreporting and how to detect them is, but ever since we had PTH, the amount of people that we pick up that are actually drinking, and they'll swear to you that they don't. There's a lot of amateur actors, so to speak, that are exceptional. I've seen 350 PTH of 350, and they'll look at you right in your eyes, crying, and say that they haven't had a drink in years. The PTH doesn't lie. Finally, what would be the role of living donor living transplantation, LDLT in Pittsburgh, in patients with alcoholic hepatitis? Now, with those two possibilities, by having more family support, there might be a selection bias. Well, or a friend who has more support than others. You also have the donor, which will be pressure to take care of yourself. So we have to expand this, because in countries where they have little donation and deceased donors, now, if you come in with liver disease, self-inflicted, NASH is self-inflicted, but if I have a donor, I can perform a quick assessment if they failed on steroids, and I won't expect MOF. So here it's quite favorable, but you have to perform the workup. There's no arguments that would say that these patients couldn't have a live donor. Why not? because NAFLD, why NAFLD and on the others? So now, hypothetically, it's possible that they have less relapse and do better, but we have to confirm that. So it's a speculation. I love that the questions, we've been getting a lot of questions, very motivating because we take an interest in the patient with the high risk with alcohol. And here I'm being asked for Dr. Luis Antonio Diaz, if you consider that the CAGE test, the pre-transplant test, the audit test could be stratify, conduct, and follow-up of patients in post-transplant. What do you think?
Escuché del test de audit.
We talked about audit
o el CAGE podrían ser
CAGE.
como herramientas
Could they
de
be used as tools for screening pre-transplant? Thing is, audit is a screening strategy, but not in this scenario. We only know that this scenario, the patient has associated hepatitis associated with alcohol. No, these are problems that there might be a disorder from alcohol consumption. So what we should do is perform an evaluation of different aspects, as shown by Dr. Bataller, as Dr. Winder from Michigan, psychiatric evaluation, hepatologist assessment, and so forth. But specifically in the audit, we shouldn't confuse the fact that this is for detecting possible patients with disorder from alcohol consumption. So it's another scenario, not alcohol-associated hepatitis. I agree. You have a study from Michael Lucy published recently that showed that audit pre-admission for alcoholic hepatitis had no impact on outcome. So we don't need to perform screening. They all have an AUD, severe alcohol consumption. Thank you. I will be trying to pick two final questions. Here we have an interesting one. We have tools. Do we actually have objective tools for screening and performing adequate selection through surveys, scales that you consider that could be useful or orient us when it comes to deciding who to transplant and who will be a candidate or a poor candidate because it could have a relapse?
Difícil pregunta, muy buena. Hemos de ir a cosas para ser más justos.
Well, we have to try to get more objective. But here we have an example in the Accelerate trial, the predictors, and how to accept the diagnosis. Well, how can you scale this objectively? So there's a lot of scores. Here we have another example.
3 o más deshabituaciones de alcohol.
3 or more. Alcohol crisis was a contraindication. So do you count out patients or inpatients? Well, to need to resort to objective data, we shouldn't expect for it to be as objective as looking at a tumor, for example, on an imaging test. There'll always be a level of subjectiveness and subjectivity and scales of gray and qualitative aspects. It'll be nearly impossible for something to be 100% objective and reproducible. But it should be attempted, of course. We shouldn't stop trying, though it is difficult. All right. I'd like to ask each one of our panelists to end with a final comment. Dr. Diaz, go ahead.
Ahí sí, era en relación a lo mismo de...
Well, along the lines of, it's difficult to make a decision that will have an impact on survival from 20% to 80% with just a survey. As you showed, we've had patients that with autoimmune hepatitis, you perform the Stanford questionnaire and it comes out that they're poor candidates due to smoking, and you transplant them and they actually do quite well. So your evaluation has to be in a team. And as Dr. Bayer mentioned, all of these patients, just as patients who consume other substances and who have other diseases such as hepatitis C or autoimmune, there has to be psychiatrists, they have to go over it, social workers, occupational therapists, all of them have to be working in this. So this is something that has to be done as a team. I believe that we have to work in Latin America for trying to implement this,
como programa y también
to
ocupar
be
las
accepted as a program and to occupy the tools that are used in other parts, such as markers. Dr. Garrido, your final words for the audience? Well, along the lines of what's been said, now scores shouldn't just be used alone to define who will be a good or bad candidate for transplant, and with countries with low donation rates, such as in Latin America or even in our country, to evaluate in centers that have more experience on live donors, living donors, as was mentioned, and the use of donors with expanded criteria, aging patients, or with other types of hepatitis. We have universal treatment, could be an option for increasing the rate of transplant for these patients. Thank you. Dr. Chavez, if you could give us some final words for the audience, if you could give it in English so that our translators can perform the interpretation. Dr. Roberta.
Thank you, Fatima. Discussions like these are important, and we have to focus on a careful selection of patients to avoid the risk of a futile liver transplant, regardless of the etiology, as other conditions like metabolic fatty liver disease may also be associated with behavioral choice. As alcoholic liver disease. So it's important to study about this selection of patients. Thank you.
Excelente, muchas gracias.
Thank you very much. And Dr. Cecilia Cabrera, if you could give us your final words.
El mensaje final sería que, si bien es cierto,
It would be granted, it's true that in countries we have shortcomings with donation. We have to open our minds and not preclude having this conversation so that we can make early transplant a reality. Well, to close, Dr. Bataller, if you have any final words. Thank you very much for the comments. Now, one thing I haven't mentioned, which changed the way in which I've looked at these patients. I have visited with the addiction counselor simultaneously. We're physically present, and that has been life-changing because I've learned a lot, and they have learned from me. They understand. I wouldn't be as experienced as I would be now if it hadn't been for the advice and example of all the addiction specialists, which are with me every day at the clinic. Now, learning gets interesting when you have two different specialists. We tend to work independently from one another, and that makes our work lower quality. So working together really increases quality. Thank you. Thank you. I'd like to close our fifth session. I'd like to remind you that we'll be continue with this series of webinars, and ALA Congress is coming up, so don't miss it. Dr. Arab, if you would like to give us a final message from the organizing group, go ahead. Thank you. I'd like to thank Dr. Bataller for being with us and the amazing talk, our panelists, our moderator, Dr. Fatima, and our panelists, Dr. Diaz, Cabrera, Dr. Garrido and Dr. Chavez Arauco for the excellent Q&A. I'd like to thank ILTS and Ale for the support that they've been giving us for these webinars. The next will be in September. So we'd also like to invite you on the ALEC Congress, which will be held in Buenos Aires between 6th to September 9th. And I'd like to thank Teva Laboratory, who been supporting us for performing the web platform and the interpretation service. So thank you very much. Good evening, and you're invited for our next activities. Thank you.
Que estén bien.
Gracias.